Thanks again for joining us for our virtual forum, Methadone, Sorting the Science from the Stigma. And we are pleased to introduce our presenter, one of BrightView's medical directors, Dr. Amit Patel. Dr. Patel?
All right, thank you. Hopefully everyone can hear me. If someone can confirm, please.
We can hear you loud and clear, Dr. Patel.
All right, thank you so much. All right, so thank you everyone for joining, and glad to be able to present this topic on methadone, kind of sorting the science versus the stigma. And so if we kind of pause to think about, like, why are we discussing this topic, right? Why do we have to discuss about methadone and the stigma associated with it? So I'll give my own example, my own background. So I started medical school in 2004, finished in 2008. And during my medical school training, there wasn't a whole lot of education given and time given essentially to the topic of substance use disorders or addiction. And so that's kind of, and that's universal to a lot of, training programs. And even after I finished my med school, went on to doing my training in internal medicine for 3 years, from 2008 to 2011, there was very little exposure to substance use disorder. As far as formal training, there was almost minimal. And that's where essentially most of our training was. And so mainly then when we got out of training and started practicing, we were exposed to patients who have substance use disorders kind of here and there, and it was more inconsistent. So that's where, like, the baseline is for a lot of people, a lot of physicians, a lot of nurse practitioners, PAs that come into the realm of medical practice. They start out with this baseline, and so that's where, unfortunately, some of the stigma does arise, because what ends up happening is that people who suffer from substance use disorders, and when they go to the hospital, like, for example, I work in a hospital now, and people who come to the ER and come to the hospital, they usually don't come to the hospital for the intent of wanting treatment for their substance use disorder. They're usually in the hospital because there's something else going on, like they have either cellulitis, or they are feeling sick because maybe they have an infection in their blood from IV drug use or endocarditis or something along those lines. And so when they come to the hospital, they're not feeling well, they're uncomfortable, they're withdrawing, they might be agitated, they might be getting angry at the staff. And that kind of encounters is what shapes people's perception of what people who are suffering from substance use disorders are like, that they're, very hard to deal with, and it's a challenge overall. And a lot of practitioners choose to not, want to deal with this population. So unfortunately, that's where the stigma starts. And thankfully, the one thing that we see in our addiction treatment centers is almost the complete opposite. We have a lot of patients who come to us on their own. Most of them are not required to be in treatment. And when they come to our treatment programs, they want help, and they are willing to comply with the requirements of the treatment program, get on medication, do counseling, and things like that. And from that, we see people do much, much better. And so that's kind of the premise of why treatment works, and that's why we do it. And that's the reason why we also have to have these discussions, because it's more of the education that we need to provide to a lot of the people who are, whether it's patients themselves or their family members, or staff members in our treatment programs, medical professionals, the communities. Everybody needs to kind of understand that there is a way, a solution to this problem, which includes medication-assisted treatment, as well as counseling that helps people to get better. So next slide, please. So the agenda for today's discussion is mainly to discuss methadone, so how it works, and then discuss the regulation and compliance factors that surround methadone dispensing in the United States. Obviously, as we know, the intent is just to discuss the stigma and misconceptions that surround the treatment with methadone, and then look at the goals of methadone treatment and what kind of patients are good candidates for that treatment. And then looking at how that benefits the patients as well as the communities. We'll cap off with a couple of success stories from patients that we've had, and then finally have some time left for questions at the end. So next slide, please. All right, so the history of methadone. So first off, let's talk about why are we using methadone and what is methadone. So methadone it's an opiate. Okay, it's a full agonist. It was introduced to the US in 1947 mainly for pain management. And then by the 1960s, they realized that it also could have a benefit for treating opioid use disorders. And so that's when it started being prescribed in OTPs, which are opioid treatment programs, for the intent of treating OUDs. So essentially, for about 60 years now, methadone has been prescribed in the United States for the purpose of treating people who have opioid use disorders. And because it's been around for 60 years, it has a lot of scientific data to back it. The other alternative that a lot of people might be familiar with is buprenorphine. And buprenorphine has also been around since the 1960s, but really FDA approved for the treatment of OUD for buprenorphine started in 2002. So relative to buprenorphine, methadone has been around a lot longer, and therefore we have a lot more data to back it up. And it has shown to decrease opioid use. It has been very effective in, preventing deaths. It has been very effective in making patients better overall. And so I just want to talk real quick about why do we use methadone or buprenorphine in the treatment of an opioid use disorder. So typically when somebody starts using opiates or abusing opiates and eventually gets addicted to opiates, majority of our patients, and this is my own experience from talking to patients I've seen, or I've been at BrightView since 2016, and so by now I've seen thousands of patients, and talking to them about how they started their drug use. Most of them started as recreationally, and a lot of them when they were young, in their teenage years or so. Some patients obviously started because of other factors that led to the need for self-medication, whether it was, trauma when they were growing up or chronic pain, things like that. But a lot of people do start as recreational. So they're chasing the high, the euphoria that comes from the drug. But after they develop a dependence, because they've used it more and more consistently, their body has gotten used to it, they start having a dependence on this drug. And once that dependence happens, then withdrawals start happening. And so when the withdrawals happen, that's really what the patient now seeks relief from. So majority of our patients, when they see us after they've been dependent or addicted to these drugs for a long period of time, and by the way, there's a difference between dependence and addiction, and we'll talk about that later. So once our patients have been addicted to their opiates for a long period of time, most of them say the same thing, that I don't even get high anymore. And that's not even the goal of why I use drugs. I just use drugs, or I use opiates on a daily basis just to not feel sick. So the withdrawals are the primary concern of that patient. And so when you look at the treatment options, you have to have a treatment option that fixes that issue first and foremost, which is controlling their withdrawals and cravings. Because once you control their withdrawals and cravings and they feel better, then they can focus on other aspects of their addiction and their life that have essentially been sacrificed because of the opioid addiction. So first things first is always to control the withdrawals and cravings. And that's why you have to use an opiate. Excuse me. So as far as methadone or buprenorphine, the reason why we choose these two medications, and methadone is the topic of this discussion, is because it has to be a longer acting opiate. So looking at the drugs that people use on the streets, if they're using oxycodone or they're using fentanyl, those are shorter acting medications or drugs. They usually last 4 to 6 hours. So a patient is used to doing this drug every 4 to 6 hours throughout the day, all day long, to just maintain, to not be sick. So when we choose a treatment, it has to be something that lasts much longer, because we're trying to break the cycle of needing something every 4 to 6 hours. So that is why you choose the medication that lasts longer, is much more stable. It doesn't peak and trough or have valleys in how the medication works. You want it to be a much more steady state, sustained release of the medication, having a sustained steady state concentration in the bloodstream. So it provides them relief of relief of withdrawals and cravings for a longer period of time. And so that's what methadone does. That's what buprenorphine also does. And that's the reason why those two medications are chosen for the treatment of opioid use disorders. Because An alternative would be like, say, you could think that, hey, you could prescribe Percocets for treating somebody's opioid use disorder, but there it wouldn't work as well because it has a very short half-life, similar to street drugs. And so we wouldn't accomplish the stability that methadone and buprenorphine offer. And so that's the reason why methadone is chosen. So going back to it, as we mentioned, it has a lot of benefits in terms of increasing retention and treatment, alleviating all the symptoms that make patients uncomfortable so that they can be more successful in their treatment and sobriety. Next slide, please. So methadone, it is a long-acting, as we mentioned, full opioid agonist. And so essentially, what does a full opioid agonist do? It has the highest activation at the opioid mu receptors in the body and the brain. And the reason why, as we mentioned, that we use this medication is that you want the medication to activate those receptors to alleviate the symptoms and the cravings that the individual has. One other alternative, as we all are familiar with, is buprenorphine, and buprenorphine is a partial agonist. And so it has the same similar effects as methadone, but not all the way. It is not a full agonist, it's a partial agonist, so it will have still an effect on the opioid receptors. It will still relieve withdrawals and cravings, but methadone does it to a more fuller extent. So there are some people that where buprenorphine doesn't work for them, and that's where methadone has been a good option. And that's what we always say with every patient that we see. It's always individualized treatment. It's always good to have different options in terms of how you can address the medical issue. Another treatment option is naltrexone, and naltrexone is an opioid receptor antagonist. So it does not have any agonist effects like buprenorphine or methadone do. It is only an antagonist. And so it would never be used to help with relieving the withdrawals, because as we mentioned, that's the first and foremost thing that people want is relief of their withdrawals. Naltrexone would not be helpful in that regard. So it's really used only for patients who have already achieved some time of sobriety. And then the medication like naltrexone is used to help with maintaining the sobriety. So there's a concept of the door with the chain analogy, and we'll be using a lot of parallels during this talk to kind of give some relevance and context to what we're discussing here. So next slide, please. So here, the concept with the doors. So essentially think of it this way, like that closed door is what an antagonist would do, like naltrexone. So in essence, when the door is closed because of that antagonist binding to the receptor, it does not allow any opiate effects to happen. If somebody were to take an opiate, it wouldn't be able to pass through that door, therefore no opiate effects. The middle door is where it's partially open, so that's the partial agonist, which is buprenorphine, and buprenorphine does allow, as we said, some opiate effects to happen, so it allows relief of withdrawal symptoms and cravings, but it doesn't do it to the full extent like methadone does. Methadone is the door to the right, all the way open, full agonist effect, and therefore, for some patients, better efficacy because some people have higher tolerances. And so that's where methadone has a much better effect. And so that's the graph on the right that we can see where we have a full agonist with on that chart. So you see the opiate effect, right? That's your y-axis or the vertical axis, and your x-axis, the horizontal axis, is the one where you see partial agonist effect or opioid effect, which is about midline versus the full agonist in methadone. And the antagonist, or naltrexone, has essentially no opioid effect at all. So again, it's all just based on the individual's treatment requirements, allows us to have the right medication option for them. Next slide, please. So methadone comes in different forms, primarily in the opioid treatment programs, which are the methadone clinics, the dispensaries where methadone is being given for an opioid use disorder, mostly gives it, they dispense in the liquid form. And that has been chosen as a means to minimize diversion, which is people trying to, unfortunately use the medication for a different purpose. And that is minimized usually by using the liquid form, because people have to do an observed dose. It's in front of a nurse. They have to swallow the medication, and then they would be able to, go about their day. There are other options that are available, like tablets or the wafers. Those are usually used in the pain management realm, but not in the realm of treatment for opioid use disorders. So as we discussed, methadone, it's a full agonist. It binds to the same opioid receptors. And once we get the person to a stable dose of methadone, it blocks the euphoric effects that one of the illicit drugs like heroin or fentanyl or even oxycodone would have, is because the methadone is occupying those opioid receptors. Those receptors are satisfied. They're essentially, there's no need, there's no withdrawals, there's no cravings. So therefore, the patient doesn't have any desire to use any illicit drugs. And by doing that, by having a patient stable on the dose of methadone that works for them, there's much less risk of overdose because the person's not using any illicit drugs. The way we titrate up the medication dose when somebody's on methadone is we're increasing their dose about every 3 days, giving a chance for each dose to have a full effect. And once the person has gotten to the point of where they're not having any more withdrawals, they're not having any more cravings, they feel stable, that's when we stop adjusting their dose any higher. Essentially, that is the dose that is working for them, and we essentially leave it alone. And then at that point, focus on other aspects of their treatment to help them to maintain control of their substance use disorder. Next slide, please. So discussing about medications, we touched on this a little, but just wanted to elaborate on it in terms of the options. So again, drawing the parallel to other chronic medical conditions. So the first thing to know is that any substance use disorder, and in this case, opioid use disorder, is a chronic medical condition. And the thing about chronic medical conditions is that they have to be controlled. Unfortunately, there is no cure. We wish there was, but we have to come to terms with and accept that part. And that's what we advise to our patients too from the beginning, that the goal here is to help you to control your substance use disorder, because unfortunately, it is a chronic medical condition with relapse potential in the future. So with parallel chronic medical condition like hypertension or diabetes or hyperlipidemia, which is high cholesterol, there's many different medication options that are available. As you can see, the list of hypertension medications that are in that box, and that is not an exhaustive list. There's more that are always been there, and this because hypertension it's very prevalent. It's a very common thing, and a lot of people have adverse consequences worldwide from uncontrolled hypertension, and as a result, there's many different treatment options. With opioid use disorder, again, with the stigma that surrounds it, there hasn't been as much research into different treatment modalities. It's more limited. And so thankfully, we have 3 FDA-approved medications for the treatment of opioid use disorders. But at the same time, it's only 3. So it's buprenorphine, methadone, and naltrexone. And so it's important for us to know that with the limitation of only 3 options, we have to essentially keep an open mind on having all 3 options available to our patients and then tailoring their treatment individually, because it's not a one-size-fits-all. One medication might work great for one subset of the population, and then it might not for a different subset. And so that's where we have a different option available, thankfully. And so that's really the premise, is like just keeping an open mind about the treatment options and essentially using each treatment option as best as it can provide benefit to the patient. Next slide, please. So the one thing to know in the United States, methadone is highly regulated compared to some other countries in Europe, for example, where there's less regulation. And so every country is approaching it from a different way. But in the US, we can assume that part of the reason why is, unfortunately, part of the opioid epidemic was probably enhanced by some practitioners that were perhaps prescribing too much of the opiates, the oxycodones and the Percocets and the Vicodins and Norcos and things like that. And that's what contributed, unfortunately, to the opioid epidemic. So these were medical practitioners. So as a result, the government has considered a more regulated environment to essentially provide the treatment, but also minimize the risk of abuse. So that's why in the United States, and there's different ways of, there's different viewpoints on which one is a better option. Europe has a different mindset on this, but we have access to methadone in these methadone treatment programs and the OTPs. And these are regulated programs, but they still have open access to essentially any patient who has an opioid use disorder can be admitted to the OTP, depending on the payment models that are different states have. But the access to treatment is still there through this opioid treatment programs. And so, as I said, I mean, the intent here is safety. The patient safety is the utmost of importance, and that's the reason for the regulations being in place for these opioid treatment programs. They have to abide by certain rules. They have to essentially maintain their accreditation. There are dispensing limits that are imposed to minimize the risk of a treatment program, perhaps, prescribing medications more than they should. Right? There's take-home rules that are also regulated. There's regulations regarding patient monitoring, privacy, staff training, keeping of records. All of these things are been put into place with the intent of patient safety, so that we can essentially make sure that we're doing the right thing for our patients, essentially helping them with controlling their substance use disorder, their chronic medical condition, and minimizing any adverse consequences from the medication to them. So admission criteria also are quite strict. Typically, patients over the age of 18 are the ones that are allowed to be in these treatment programs. And ideally, somebody who has had at least 1 year of opioid addiction. Now, typically, obviously, that's based on what the patient tells us, and then us looking at objective drug testing also, to determine if this person has a substance use disorder, opioid use disorder for at least a year. There are some exceptions to this. Obviously, if it's a pregnant patient that has still perhaps not had a 1 year of being dependent or addicted to opiates, they could still be admitted to an OTP for treatment, because there you want to minimize the risk both for the mother as well as the child. And people who are also been incarcerated recently. So people who have had a history of an addiction, they were incarcerated, and during their incarceration, they achieved sobriety. But the risk of them relapsing is much higher when they get out of that incarceration, because the environments, they're back in their old stomping grounds and around the old environment. And so the risk of relapse is very high, but they have lost their tolerance for the opiate. A lot of people don't realize that part. And that's when we hear of the stories of when people leave jail or they leave an inpatient program or something, and unfortunately they relapse because of the kind of the memory of using, or their friends or family members who are using around them, and they relapse. And unfortunately, a lot of them end up overdosing and not making it. It's mainly because of that. They've lost their tolerance. So that's where these rules are a little bit more flexible in terms of people who have recently been released from incarceration. They can also be admitted to these treatment programs. Or anybody who's been in an OTP in the past can also be admitted to an OTP again for treatment. Next slide, please. So looking at a lot of the stigma or misconceptions and some of the realities of treatment for opioid use disorder surrounding with methadone. So first and foremost, a lot of misconceptions are there regarding addiction being a choice. And typically that is not true. You can say that there is some choices that an individual made, like for example, when they were young and they started doing this recreationally, and then they unfortunately couldn't stop after that. So those choices might have led to the diagnosis, essentially to acquiring a substance use disorder or an opioid use disorder, and then having the diagnosis of it after that. But by itself, addiction is not a choice. A lot of the times, people's addictions stem from the high risk environments that they were in. Again, how they got exposed to drugs and when they were young. Many people started in their teenage years, and so it was in their environment, right? We have stories, again, as I mentioned, I've seen thousands of patients, so many stories of varying, capacities. Like you've had some people say that Like I remember one patient who said that her grandmother used to give her Percocets to do household chores at the age of 12 or 13. Or, somebody else who started smoking weed when they were 5 with their father, right? Or like somebody else who got injured playing sports when they were a teenager and got prescribed these medications, and they got them for longer than they were supposed to, and it was hard for them to get off. But sometimes it's psychological trauma, from their earlier years, and then the desire to escape those is what leads people to self-medicate, and that self-medication eventually can lead to an addiction. So that's where the premise of how addiction starts for a lot of people is not really just a choice, but it's more complicated than that. The other thing to know is that, as I mentioned, that substance use disorders are considered to be chronic medical conditions. And chronic medical conditions don't have a cure. The intent is to control. So a parallel is diabetes. With diabetes also, an individual has to, a lot of times they have to take medications. There are very few fortunate people who can just do diet and exercise and control their diabetes. But most people, they need medications in order to control their chronic medical condition. So it's the same thing with opioid use disorders too. And the next point about substance use disorders, people who have them are typically criminals, and that's also another misconception or stigma. And a lot of times the criminal activity is a consequence of the addiction, but not necessarily like the cause of it or always associated with it. Because there's many people that we know who are essentially functional addicts. They're keeping a job, they're keeping their lives together, but they still unfortunately have the addiction. But then there's also another subset of people where, as we had mentioned before, they started out with recreational use, they got dependent because of the tolerance, and then they started having withdrawals, and they had to continue to use. And then once they continued to use, then that became their entire daily routine, especially when you're using a drug that only lasts 4 to 6 hours. Your entire day surrounds just the drug use. And so these people, unfortunately, then start losing control. They have lost control of their daily routine. They unfortunately then lose their jobs. They have no means to pay for the drugs, but all they want to do is feel better. They don't want to have withdrawals. And so they're then using, it becomes like essentially the fight or flight response, like, the survival instinct kicks in on like, how do I make it? And sometimes people have to resort to being criminals, just commit crimes in order to maintain their habit, which is stealing and committing small crimes in order to just maintain the addiction so that they don't feel bad, so that they don't have withdrawals. But that doesn't mean that every single person that is has an addiction or a substance use disorder is a criminal. And we see that by the fact that once people get in treatment and get better and their withdrawals and cravings are better, the crime rates go down. Because again, otherwise you would think that it would just persist, right? The criminal activity would still persist, but it goes down dramatically once they get in treatment. And then the next point, methadone take-home doses and increased overdose deaths. So that was another theory that was really tested during the pandemic. During the pandemic, it became essentially more apparent that we needed to be able to give people more take-homes, because in the past, when we were giving people take-homes of methadone, it was based on a strict phasing criteria, which was based on how stable was the patient in their recovery, combined with time in treatment. And the time in treatment part was pretty long periods. Like it had to be essentially every 3 months, the patient could get one extra take-home, to kind of simplify it. So during the pandemic, we were able to give more take-homes. And of course, the providers, the people who were prescribing and dispensing the methadone, they were still cognizant of which patients were the right patients to be giving extra take-homes to. So by being more, cautious, but still having that leniency of being able to give more take-homes to those patients, the patients that were doing well got more take-homes. And since they were doing well, there was no reason for why there would be increased overdose deaths. The people who weren't doing well were monitored more closely and perhaps would not receive as many take-homes. So as a result, we didn't see increased overdose deaths during the pandemic with more leniency, and that's the justification of why we can be watchful and careful with our dosing and with giving medications to take home, and patients do well. And it helps them because it is a challenge to have to come into a treatment facility every single day, especially, I mean, a lot of our patients are not coming from like the means to be able to have transportation on a daily basis and have the time if they're, trying to keep jobs and take care of their families and things like that. The next point regarding methadone, trading one drug for another. So we have another slide where we'll touch on this topic a little bit more, but that is an important topic to discuss. And then the next one about people falsely believe that you can tell when someone is on methadone. Typically, unless somebody's abusing their methadone, they're on too high of a dose of methadone, they're not going to be high on methadone. So you're not going to be able to tell just by looking at somebody that this person's on methadone, just like how, somebody is high on fentanyl. We rarely see that in all the patients that we take care of. And most often, if we do see that, it's because they're using illicit fentanyl on the streets. And so with the goal of treatment, as we mentioned, the goal of treatment here is to achieve recovery. And that recovery, which means relapse prevention, which means improvement in their lives, which means improvement in their health, mental and physical, that happens because of the medication. So the parallel here is, like, say, somebody who's got diabetes and they get started on different medication regimens, eventually maybe end up on insulin. And the insulin works well for controlling their diabetes, right? So then you would continue the insulin because it is working. But a lot of patients, even who are diabetics, because I work in the hospitals, I see it. This conversation, sometimes the patients come back and say that, oh, my diabetes is well controlled now, so I don't need this medication anymore. And we have to advise them that your condition is controlled, your diabetes is controlled because of the medication. So you have to then stay on the medication in order to maintain control. And that's what it is here in opioid use disorders also. The maintenance of treatment with methadone or buprenorphine or naltrexone is the primary goal to help them to maintain their sobriety. So choosing medication, or MOUD, which is medication for opioid use disorder as a part of recovery, is really the best choice. Again, the parallel to any other chronic medical condition that it's multifactorial treatment. You're looking at medications as a means to achieve sobriety in this case, just like you're looking at medications to achieve control of the diabetes or the high blood pressure. And so it's a treatment modality that works, and that's the reason why we use it. And then the last point regarding withdrawal. And some people have been, told that, hey, I mean, your withdrawals is just like the flu, just kind of deal with it. Just why do you need to go to treatment? Why just detox off of your opiates? And it's just like going through the flu. And I would say that this essentially this withdrawals is much worse than the typical flu. And because if you think about it, most patients who are withdrawing, they're withdrawing on a daily basis. That's the reason why they have to use drugs on a daily basis, and they're withdrawing probably multiple times a day. A lot of patients use the drugs like preemptively to try and prevent their withdrawals from happening. So they're dosing themselves with drugs every 4 to 6 hours. But a lot of people don't have the means to get that every single day, right? I mean, the drugs are not always consistently available and things like that. So they're going through withdrawals very often, and they don't get used to it. Otherwise, you would think like, hey, you just get used to your withdrawals and, it's not that big of a deal. But it is so uncomfortable. It is much worse than the average flu symptoms. And that's why they seek relief as soon as they can get relief. And they know what works to get them relief. And that's where the cycle of that habit of using drugs constantly, it just can't be controlled as easily. So to be able to just go through withdrawals like it's the flu it's much more challenging than we realize. Next slide, please. So just some excerpts that of patients' accounts regarding how flu, how significant their withdrawals are compared to the flu. So like one excerpt is this: there is no consequence worse than being dope sick. More than once, I've read this phrase describing opioid withdrawals, that the patient will experience flu-like symptoms. And the patient goes on to say that this is the most inaccurate statement in medicine. There is no flu that feels like being trapped in a burning room with no way to get out. The flu doesn't leave you with psychic death. It is the most brutal experience I've survived. I have PTSD from withdrawing, not from using. Next slide, please. So coming back to that topic of, are you trading one drug for another? So we touched on this initially when we mentioned on why do we use methadone for the treatment of an opioid use disorder or buprenorphine. And it's really that part is that if we go back and look at what is dependence on a drug versus addiction. So essentially when somebody starts using a drug or are prescribed the medication, Percocet or Vicodins or Norcos or whatever it may be, they say, for example, in a pain management clinic, right? If somebody gets prescribed that medication, eventually their body gets used to it. They have a dependence. Dependence means withdrawals. So if they stop taking that medication, they will have withdrawals. But as long as they keep taking the medication the way they're supposed to, they're not abusing the medication, they're not overtaking the medication, things like that, then they remain stable, they remain level. So there's a lot of patients in pain management clinics prescribed Percocets, Norcos, different age groups, anywhere from 30s or 40s up all the way up to 60s and 70s. And majority of those patients in pain management clinics, they don't get addicted to their prescription. But in the illicit realm, where people are abusing these medications in the beginning, as I said, they still go through the same cycle. They get dependent on the medication or drug, they have withdrawals, and then they use more and more and more of that drug to relieve those withdrawals. And then they start making other decisions in their life because the addiction starts consuming their life essentially. So all these people then now they're addicted because they've sacrificed their physical well-being, their mental well-being, they've sacrificed relationships, they've lost their jobs, they don't have housing, they're homeless on the streets. These are all the factors that are part of an addiction. So when we prescribe people medication for their opioid use disorder, the intent is to take them from the worst phase of their life, the worst phase of being in an addiction, back to a dependence. Okay, so now you're taking them away from where they didn't have, again, their mental well-being, their physical well-being, their relationships, their employment, all those things that were sacrificed. You're bringing them from that back to a dependence. So with this dependence, now this individual can function. They can be more stable. They can, because they're on a medication that lasts 24 hours, like methadone or buprenorphine. These two medications are chosen because they have a much longer half-life, as we discussed. So when they're stable on their medication, they can go back to being functional members of society. They can work, they can take care of their kids, they can, take care of themselves. They can be, a parent or a sibling or a son or daughter. And so that's the essence of why we do the treatment with medication. And with medication-assisted treatment, like methadone, you can see that up to 75% less likely to die of the causes related to drug use, because not just the overdose deaths, but people, especially with IV drug use, they get sick. They get, infection in their bloodstreams, which can go anywhere in their body and seed an organ, whether it's in your heart, and it causes endocarditis. And some people have died from that. Some people have had amputations because the infection gets really bad. And so these kind of complications are severely reduced by being on medication. So as it says at the bottom, successful methadone treatment, the intent is to control the compulsive behavior, loss of control, the constant withdrawals and cravings, and to make all of these conditions essentially be gone, and to put our patients into recovery or have a controlled medical condition. Again, just like the parallel of diabetes, or maybe, even you can call it being in remission, kind of like somebody who has had cancer, but now they're in remission, they're cancer free. So that's where we are trying to have patients be, in that state of being free of their disease or being in remission. Next slide, please. So the goals of methadone treatment. And so as we had mentioned already, the goals is really to just get people sober, right? Reduce harm, improve their withdrawals, their cravings, make them feel better, manage other complications that might have arisen from the drug use, ultimately save lives. and so that's the main reason of why we're, doing treatment, and thankfully we have these options available. Next slide, please. As far as who's a good candidate for methadone, really any patient that has an opioid use disorder can be a candidate for methadone because methadone has very few absolute contraindications. There's many cautions with methadone, but otherwise methadone is a medication that we can prescribe to majority of our patients. We still always recommend for treatment, it's always individualized. We never look at it as like everybody should be on one medication versus another medication, or one medication is universally better than the other. Each medication has benefits, each medication has side effects or concerns or contraindications, and we just have to apply it to the individual. So for certain people, methadone might be a good option, like those people who have already done methadone in the past. So they have that relevant past where it shows that, hey, I did well on methadone. I was sober for 2 years or 5 years or whatever time frame, and I was able to function and do all the right things. So there's that relevance there from their own history that helps them to say that, hey, I want to get back on that medication. Some people, as we discussed, with methadone being a full agonist versus buprenorphine being a partial agonist, some people, they don't get the full benefit from being on buprenorphine, and that's where methadone can be an option for them. The other challenges with getting on buprenorphine or naltrexone is that with buprenorphine, you have to be in moderate withdrawals before you start buprenorphine, because if you start buprenorphine too early, it can actually make the withdrawals worse. And that is a very uncomfortable thing for a lot of patients to go through. We have had a few patients who have been through precipitated withdrawal, and they will remember that withdrawal as the worst withdrawal they've ever had. And so a lot of people are reluctant, once they've been through that kind of precipitated withdrawal, to try it again. So for those patients who, never, if they weren't able to abstain from the illicit drugs for long enough to be in moderate withdrawals, or sometimes it's also that the fentanyl on the streets, it's of variable potency. There's variable metabolism within the individual patient. And so some people don't go into the withdrawals after 24 hours, for example. It takes them longer, or they're just not able to wait long enough. With naltrexone, it's even longer. You have to be off of the drugs for 7 to 10 days before you can get on naltrexone. And naltrexone only works for cravings. As we said, it doesn't do anything for withdrawals. So it's very hard for anybody to wait that long. They would have to go into an inpatient detox, or really have a very, very strong will to lock themselves in a room and not get out and not have any access to drugs. Because, as we mentioned, when you're really sick, you just want relief from your symptoms, and they know what they need to do to get that relief. So it makes it very hard for people to be able to get on naltrexone. Buprenorphine, still challenging, but more feasible. So that's where methadone comes into play, that you don't have to wait. You don't have to wait for the 24 hours. You don't have to wait for the 7 to 10 days. And you can get people on this treatment earlier. We obviously would make sure that the patient is safe. So if they're coming in and they're under the influence, or they're intoxicated, or they have other vital derangements, we might not offer them methadone, off the bat. But if somebody comes in and they had used fentanyl even a few hours ago, but they're not intoxicated, their vitals are okay, they otherwise are safe to be able to start methadone, we could start them on methadone immediately. Next slide, please. So again, choosing methadone over other MOUD, we touched on this already, essentially people who had a positive experience, and anybody who's had, the challenges of getting on buprenorphine or naltrexone with the timeframes needed, or they've had some side effects from those medications. That's where methadone, again, would be a good option. And again, as we have to also keep in mind that we only have 3 medication options available for the treatment of OUD. So at least it's good that we have these 3 options, and so we can tailor the treatment to the individual. Next slide, please. So looking at some of the benefits of methadone treatment, and just wanted to kind of show some diagrams, a pictorial view of how we see the benefits. So in this case, this one is really talking about the concept of if people have been on treatment for a while, and again, going back to that stigma about hey, why do you still need to be on methadone? If you're sober, get off the methadone or get off the Suboxone. And this slide illustrates that point. This is a study that was published in 1991. And at that time, it showed that people who were in treatment on methadone and then they were tapered off their treatment, by 12 months of being off the methadone, almost 80% of those people had relapsed. So it goes back to that point that this is a chronic medical condition, unfortunately has a high relapse potential. And to minimize that relapse potential, it's better to use a medication, perhaps on a longer term time frame, that allows the individual to maintain their sobriety and continue to work on themselves, work on their life and their learning how to deal with their triggers. And essentially maintaining sobriety is really the most important factor in treatment. So if medication warrants it, then we should use the medication. Next slide, please. Another point, essentially, this is also published in 1997, looking at the HIV conversion rates. And as you can see from the pictorial, that the people in treatment by the designated by the yellow bars had much lower relative HIV conversion rates versus the purple bars, showing that treatment is beneficial in preventing chronic infectious disease like HIV or Hep C and things like that from happening. So that's the benefit of treatment again. Next paragraph, please. I'm sorry, next slide. All right, and then again, looking at crimes also. So treatment helps people to improve their lives. And as we mentioned earlier, like it reduces their need to commit crimes, because a lot of times the crimes are being committed just to maintain the addiction. But once they are free of those symptoms, once they're not withdrawing, once they're not craving, they are stable in their recovery, they have no reason to commit the crimes. So you can see here that people who are in treatment have a very low relative crime rate versus those that aren't. Next slide, please. So there are some situations where methadone might not be ideal. As I mentioned, there's very few absolute contraindications. Obviously, if somebody's allergic to methadone, that's very rare. Or have intolerable side effects from methadone, that might be a reason to not use it. Another typical absolute contraindication is really a long QT syndrome. And a long QT it's an interval on an EKG, and an EKG or ECG, which is an electrocardiogram. It's a pictorial of the electrical activity of one's heart. And so the rhythm that the heart has, and on that rhythm, there is rhythm strips. There is this interval called the QT. And if that QT interval is longer, congenitally, so if the patient was born with that long QT syndrome, then having methadone might increase their risk more for a fatal arrhythmia called torsades or torsades de foie. And torsades is a fatal arrhythmia that essentially needs immediate intervention. It's a very, very rare thing for people to have a congenital long QT syndrome. There are people who do have a prolonged QT for other factors. Medications, there are many medications, antidepressants, mood stabilizers, antibiotics that can cause a long QT syndrome to happen. And that's where we monitor these patients. We do EKGs to, as a safety measure to make sure that these patients are safe to take the methadone. But otherwise, a long QT syndrome is an absolute contraindication. And then any other concurrent medications, like that were sedating, like if somebody's prescribed benzodiazepines, that would be a caution. Somebody who's abusing alcohol, because that can also cause sedation and potentially respiratory depression, depending on how much they used. Again, that is a caution where we have to be careful when we're prescribing methadone. But again, those are not absolute contraindications. There are certain situations where if somebody has like a low to moderate opioid tolerance, there might be a question of whether they should be put on methadone. So again, it goes back to this individualized treatment. We have to look at the situation of that patient, their circumstances, discuss the treatment options, and see if methadone would be an option, or perhaps there is a better option like naltrexone or buprenorphine for those patients. Then there's also the thing of transportation. That is a requirement, especially earlier in the phase of recovery. Patients are coming on site daily to dose. There is some flexibility that is allowed, but again, on a case-by-case basis, we use that. But majority of our patients are coming every day to dose until we get them to a stable dose and they're illicit drug-free. And at that point, then we can give them take-homes. But until then, dependable transportation every day, 6 days a week is a requirement. There are some challenges with some jobs, and that is, there's other factors that are kind of beyond our control. But if some people are in some jobs that require them to be operating heavy machinery, they're driving trucks, they're, lift operators, or they're maybe an airline pilot, for example. These people might have other factors that prevent them from being able to get on methadone, and we might have to use a different medication, perhaps like naltrexone or buprenorphine. But again, it's individualized treatment, as we said. We have to look at their circumstance and tailor the treatment accordingly. And one more point regarding being mental health issues. If somebody has significant mental health issues, that might make it a little bit challenging for them to come to an OTP on a daily basis, or they might miss many doses because they're not making it on site because of their mental health, and then that might make it more challenging to get them stable. But that usually means we're recommending a higher level of care first to stabilize their mental health, and then they can come back to do treatment with methadone. Next slide, please. All right, so the safety with methadone, first and foremost, we always recommend to everybody that when you're taking treatment for their opioid use disorder, it is always taken essentially scheduled once a day, typically methadone or buprenorphine, usually prescribed once a day. Sometimes they can be taken twice a day, but typically no more than twice a day. Because as we discussed, these are longer acting medications. They are what we call like proactive medications rather than reactive medications. So the proactive part is that they prevent the symptoms from happening, prevent the withdrawals and the cravings from happening. So they're supposed to be taken, as prescribed. Patients should not be taking the medication based on how they feel. It should just be taken once a day, and then it's, take it tomorrow morning, and then the day after, the next morning. Common side effects, constipation and sweating, easily managed. We have medications for those. And then, as we had mentioned, methadone can be a concern in terms of causing drowsiness and impairing the ability to drive. And that's where we are cautious in our prescribing to make sure that the patient doesn't have any of those adverse side effects. Medications can interact with methadone. So that's the other thing that we have to be careful of is whenever a patient comes to us, whether they're new or whether they're, with all the regular follow-ups that we do with these patients when we're monitoring them closely, we always want to know what medications they're on, because there are medications that will increase the metabolism of methadone, making methadone less effective, or there are medications that can do the opposite and decrease the metabolism of methadone, making the methadone effectively more effective than you want it to be. So it can make it a little bit more challenging. So that just requires us to be more careful and vigilant. And again, we had discussed about alcohol, benzodiazepines. These all can cause sedation, that can cause respiratory depression. And so we have to be careful if somebody's either abusing these medications or is prescribed these medications while they're being on methadone. But again, these are cautions. Next slide, please. All right, so what can methadone do for our patients? As we mentioned, a lot of benefits. First and foremost, reduces death rate by almost 400%, improves the health, reduces their withdrawals, cravings, improves the overall physical and mental health, reduces the risk of transmission of HIV, Hep C, allows them to have jobs, allows them to improve their relationships, allows them to not have any more legal issues and deal with whatever legal issues they do have. Overall, just much better life for the patients and everybody that depends on them and is around them. Next slide, please. As far as how long does treatment last, we touched on this. There is no set duration. It's, again, the parallel to somebody who's on insulin. There's no duration on how long a diabetic patient would need their insulin. That's a chronic medical condition. So is an opioid use disorder. So we don't really have defined treatment durations. Instead, we just, treat the individual patient, look at where they're at, make recommendations on whether they want to consider a taper once they have had a good amount of sobriety under their belt and everything in their life has been improved dramatically, so, but the patient is always part of that discussion, and it's always a shared decision making. And even when we do taper people off the medication, it's done slowly to minimize the risk of relapse, because ultimately being sober, relapse prevention is the primary goal of this treatment. And with our treatment, we always encourage counseling. So individual counseling, group counseling, those are all always beneficial in the treatment and maintaining control. So next slide, please. So as we had mentioned, intent of methadone treatment for opioid use disorder: reduces crime, saves lives, safer communities for everybody, improved public health because of the reduced transmission of the infectious disease like hepatitis C and HIV and syphilis. So, a lot of benefits. Next slide, please. So now some patient perspectives. Many of our patients have said this. I've heard this statement many times: methadone has saved my life. Or, some other excerpts are here. I tried to do recovery on Suboxone, but couldn't make it through the withdrawals. I've been on methadone and sober since day one. Or another patient saying, I've been stable on methadone for 21 years, started my own business, going fantastic. I wouldn't be here without this medication. And then even lastly, went back to school to become a counselor. I know personally how much methadone makes a difference, and I want to help people in recovery the same way others have helped me. So these are all excerpts of patients and, their true accounts. So very beneficial to a lot of people. Next slide, please. So how can we be supportive? Essentially just being aware, right? I mean, just knowing that this is a chronic medical condition, treatment options are available, following the science, being kind and patient, and being responsive when people reach out. Next slide, please. All right, so parting thoughts. Treatment, it's available. Thankfully, we have the resources to offer treatments. We have different medications. It's not a one size fits all, so we have to look at the individual patient, and medical professionals, counselors, all being part of that treatment, tailor it and use it, the medication, in this case, methadone, to help with all the benefits that we have discussed. Next slide, please. All right. Sorry, I went a little bit longer than I was supposed to, but open to any questions you all have. Thanks for listening.
Thank you, Dr. Patel. That was some great information. I know we're at the 1 o'clock mark, but if you don't mind answering just a few questions from the audience before we finish the forum. We got a question: do we know the effects on newborns when mom is receiving methadone treatment?
I'm sorry, could you repeat the question? I had my...
Yeah, no problem. The question was, do we know the effects on newborns when mom is receiving methadone treatment?
Right. So yes, there have been studies on this part. And in essence, do you offer methadone or buprenorphine for the treatment of opioid use disorder during pregnancy? And what are the effects? So universally, the recommendation is to offer treatment, because the alternative is that if there is no treatment for this individual, then the risks for the mother are much higher, and therefore the risk to the baby is much higher, right? So then, because there's a risk of, overdosing, which would affect the mother and the baby adversely, there's a risk for, infections, there's a risk for poor prenatal care, because the person is not feeling well enough to be able to even reach out for perinatal care and prenatal care. So the risk is much higher if the individual is not on treatment versus being on treatment. So now, being on treatment, whether it's methadone or buprenorphine, yes, there have been some studies showing that there might be delayed development that can happen from either one, buprenorphine or methadone, or that there might be some vision changes that may happen. But it's still, there's more studies needed to determine whether it is a true cause of the treatment. Because if you think about it, like when these studies are designed, right, you have to have people enroll in the study and be followed through in the study. And these are the people that are more likely to follow through in the study, are the ones who have achieved sobriety, but they still don't have perfect perinatal care. And their baseline that they started with, where, in the midst of addictions, they didn't have, the proper nutrition, the hydration, the proper care that was needed. And so whether those factors are what led to the essential developmental issues, or whether it is truly a consequence of the methadone or the buprenorphine, But we still look at it as a big picture that the treatment by far is a much better modality to be able to minimize the risk to the mother as well as the child.
We have a question here. Once weaned from MAT medications, is there ever a time where it is appropriate to use the medication on an as-needed basis?
Well, they're good questions. So that's what we always recommend, that you don't want to take any of these medications on an as-needed basis. Because what is happening is then the individual kind of gets used to the habit, because that's how the drugs were used, right? And again, so drawing the parallel with diabetes, that yes, even though you're adjusting your insulin based on what your blood glucose readings are, but you're still taking the medication on a daily basis to maintain consistent control. So once you flip that, especially with our patients who have a history of, taking a medication or drug for a reason, so using fentanyl to feel better, or using fentanyl because of their triggers, like stress and anxiety is a common trigger for a lot of these people. Boredom is a common trigger, and if they start doing drugs if they were doing drugs that way, and then they start using their medication, buprenorphine or methadone, in the same manner on an as-needed basis, they are creating kind of that pathway and habit there of, whenever there's a problem, I can use this to solve that problem. And we usually recommend to people that that is not the ideal way of controlling this. As we mentioned, this is a proactive medication, preventative. So the goal here is to maintain stability. So if somebody gets off the medication and later on something happens that increases your risk of relapse, we always encourage people, please get back in treatment as soon as possible. Engage in the counseling again. If you need to be back on the medication, you get back on the medication, and then stay on the medication for some time. That's usually recommended over kind of taking it on an as-needed basis.
And one last question, since we're over time. Can an inmate start methadone in prison right before they're released?
So that depends on the jail's resources. We have, thankfully, better coordination now and options with this kind of treatment options within the jail systems. But every jail system within different counties, within different parts of the country, have different resources. Some of them have medical providers on site, and they might be comfortable in starting somebody on the medication. By far more commonly, what we see is, in our experience, is that if one of our patients was on medication and then ends up going to jail, the jails will reach out to us to coordinate with how they can continue to give the medication while the patient is in jail. So that's what happens more commonly. Starting a patient on medication in jail, it's definitely a good idea, and hopefully we will come to that concept of where they get more comfortable. But it's just that those entities, the jails and their staffing and their resources, will have to be better. And they have to come around to the concept of offering this treatment. And again, that's the whole reason for this, this talk, is just to kind of reduce the stigma and open up, our minds to being more open to that concept of providing treatment in those realms. But again, it's just a case-by-case basis on which jails can do that.
Well, thank you, Dr. Patel, for your valuable input and information. It was really a great presentation. And thanks to everyone for attending our virtual forum. A reminder, you'll be receiving your CEC, a link to the recording of the forum and the slides, and a follow-up email. And we hope to see you at our next forum, Millennials in Recovery. That's happening May 21st. You'll receive a link to register for that event in that follow-up email I just mentioned. In the meantime, have a great rest of your day. Thanks so much for being here.